difficult to access at that time. So it was now subsequently used to resect sinonasal and skull base and orbital tumors. So it has really revolutionized how we've been able to learn more about the sinonasal tract. So when we look at the sinonasal specimens here, we actually submit all of the tissue, and that's really because sometimes tumors can be very focal, or sometimes a benign lesion may harbor a malignancy. So we're used to submitting all of the tissue. Now, usually that might be just a few cassettes, but sometimes it can be up to 20 cassettes of tissue when we're looking at these specimens. So in terms of sinonasal tract malignancies, and that's what I'll be concentrating on today, they're not common at all. So they're about 1% of all malignancies and less than 5% of all head and neck cancers. But they are a very interesting group because of their genetic and biological diversity. But there's a lot of histological overlap when we're looking at these tumors, and the differentials become quite broad. And so while they're not common, more and more every day we're beginning to see different lesions and newer lesions, and hopefully today I'll show you some of those tumors. The interesting thing about these is that because of that genetic diversity, there's potential therapeutic targets as well as prognostic differences which come with these tumors. So we will talk about some of the differences and potential that someday these will have some targeted therapy. So in terms of the categories of the sinonasal tract malignancies, and this is based on the WHO, there are a variety of different types of neoplasms that you can see in this area. So you have a whole host of carcinomas. There's a whole host of neuroectodermal tumors, including olfactory neuroblastomas and melanomas, and then a whole host of sarcomas, as well as other types of neoplasms. Now, what I highlighted in green here is that these categories in the new WHO all underwent significant additions and changes. So there was a lot before the WHO. I think was 2005, and the 2017 version had a lot of changes. And what I want to concentrate today is on some of these newer entities that have been described in this area. So in terms of the sinonasal tract, one thing that you will hear when we deal with neoplasms in this area is the small round blue tumor differential. And these are often undifferentiated malignant neoplasms. And it's interesting because in the sinonasal tract, many of these small round tumors can have a extremely broad differential, from epithelial to neuroectodermal to lymphoma to melanoma. And it's very difficult, even on the H&E, to make a distinctive diagnosis without doing ancillary studies. Sometimes you can look at something and say it's this type of tumor, but oftentimes we are dealing with a very undifferentiated tumor, and we're trying to decide exactly what it is. So on your H&E, you have a very broad differential diagnosis, and you can look at certain things that can help you distinguish what type of tumor you could be dealing with, like particularly clinical information, like if you know where the tumor is located, if it's in the superior aspect of the nasal cavity, you might be thinking olfactory neuroblastoma, but if it's anterior or inferior, you're probably not thinking about that lesion. And then we always take a broad approach when we're dealing with these tumors. So I wanted to start with the first case. So this was and this is pretty much our history most times, a 62-year-old male with a sinonasal mass, and it was biopsied. And this was a case we received from the outside, so we had very limited clinical history other than what was provided. So we look at the H&E. We have a very cellular neoplasm. You see right here some intact sinonasal mucosa and very cellular neoplasm, a lot of vascularity. Actually, you get a little sense at this low power of a nested appearance. So we begin to build a differential as to what we think this could be. Undergo a little bit higher power, we see this intact sinonasal mucosa, in fact sort of flattened, And then we have these nests of cells, very undifferentiated. You see some mitotic activity, and so it looks like it's very proliferative. And then we undergo just a little bit higher power. Again, we see this nested appearance, very vascular neoplasm. And so we begin to build a differential diagnosis. We look in these areas here, nests, we have sort of myxoid stroma, and we begin to build more on what could give us a nested appearance, very vascular myxoid stroma. It's a higher power, again, showing very undifferentiated. So there's really no areas that is telling us exactly what this tumor is. So I think if we just go back to our undifferentiated malignant neoplasm differential diagnosis, we have several things that come into mind. We think about either carcinomas, and there's a whole host of different carcinomas that we might think about. So undifferentiated carcinomas, neuroendocrine carcinomas, and then we'll talk a little bit about the nut midline carcinoma. Olfactory neuroblastoma, is it a melanoma, is it sarcoma? And things that we start to think about are rhabdomyosarcomas and the Ewing family tumors, or lymphoma. And I think if we look at this, probably lymphoma is not one of the first things I'd be thinking about. If you're worried about it, you could do an LCA or CD45 to confirm that it's not lymphoma, but that would be one thing that I would not think about. But we also added one thing to our differential diagnosis, and that was adenoid cystic carcinoma. So because of that nested appearance and that myxoid stroma, we thought about a high-grade adenoid cystic carcinoma. So it was one thing that got added to the differential. So like I said, you can have a whole variety of different things. So you look in different areas of this neoplasm. We actually began to see that there was a little bit of squamous epithelium above it, and it looked funny, somewhat possibly dysplastic, not really carcinoma in situ, but you could see actually there were cells within the epithelium that looked atypical. It certainly was not something that we would say carcinoma in situ, but that began to help us with our differential just a little bit more as we went into this tumor. But the thing I think that we would start to do would be some immunohistochemistry to categorize. And so this was from one of my colleagues that worked up this case. So they originally did some stains to help them think about, could this be an adenoid cystic carcinoma, or could this be some other type of carcinoma? It was positive for keratins, had peripheral staining with P63, also positive for cytokeratin 8, as well as a c-KIT. And we'll talk a little bit more about the SMARCB1, but that was retained, and that's a normal expression pattern. Negative for LCA, and negative for a whole host of other markers, including neuroendocrine markers, CD99, which we'll touch on later, and NUT protein. So I think we excluded several of the lesions on our differential, but one thing that we needed to think about, especially if you're thinking about newer entities, would be a HPV-related lesion. And so this lesion was strongly positive for P16 and positive for HPV messenger RNA. And this is an example. Here's the HPV messenger RNA expression, the RNA expression, which is actually a great test for HPV. And so this is actually an example of a multiphenotypic HPV-related sinonasal carcinoma. And this is formerly known as HPV-related carcinoma with adenoid cystic carcinoma-like features. So first described by Justin Bishop's group at Hopkins. And so these lesions exhibit features of squamous cell. And so as we were looking at the epithelium, we began to think about the potential for this lesion because there was some dysplasia in that surface epithelium. So they exhibit features of squamous cell as well as salivary gland type carcinomas. The biggest series was that reported by Bishop's group, which was 49 patients, more commonly seen in females, mean age of 54. Patients may present with a high T stage, but the prognosis is actually fairly good. I mean, I know they've just been described in more recent years, so we'll have to see about how these patients do. But in their series, 35% recurred, No patients had lymph node metastases, and no patients died of disease. But interestingly, a few patients had distal metastases, including one to the lung and one to the finger. So it may not be as indolent, but as far as we've seen, no patients have died of their disease. So in terms of these lesions, what we see histologically, and I think that was seen in this case, is a very varied histology, often with solidness of these basaloid type cells without a lot of cytoplasm. Often see mitoses and necrosis. You might see a cribiform growth, just like adenoid cystic carcinoma, and many of them will show surface involvement like I had shown you. You may see some other features. Interestingly, they mimic salivary gland type carcinomas, so that's something to think about if you're dealing with a sinonasal malignancy that looks like it has salivary gland type features. And these are some pictures taken from Dr. Bishop's paper in 2017, just to show you the varied histology that you see with these lesions. So these upper two panels are more of this undifferentiated carcinoma phenotype, often mimicking a non-keratinizing squamous cell carcinoma. But then you have these areas, and this looks very much like adenoid cystic carcinoma, some areas that had more tubular growth. And then a few other panels from their publication are these very pleomorphic carcinomas, and this one that looked like an epithelial, myoepithelial carcinoma, and then some carcinomas that had clear cartilaginous differentiation. So a whole varied histology that you can see. The majority that I have seen so far have more of the adenoid cystic or the basaloid type morphology, but just be aware that you can see some of these other types of histologies. And then one of the interesting things that they also noted in their paper, like we saw in ours, is that there was some sort of surface involvement in a high proportion of cases. And so some were clearly CIS or high-grade dysplasia, but some just basically had some cytologic atypia in the squamous epithelium. But that could be a marker for you as you're looking for these lesions, is seeing if there's overlying squamous epithelium with some atypia when you're dealing with this undifferentiated tumor in the submucosa. Here's just an example, one of the cases that we had recently, and you can see that there's these cysts with this basement membrane type material, so mimicking what we might see in adenoid cystic carcinoma. And here's just another area, and here's P16 on the right side panel, just showing you that these are HPV related. Now, to talk just a little bit about HPV testing. So there was recent guidelines that came out about HPV testing by the CAP recommendations. So in the sinonasal tract for carcinoma, these lesions are P16 positive, but according to the CAP guidelines, since this is a non-oropharyngeal site, P16 positivity must be confirmed by HPV testing. So you need to do either a PCR, an in situ hybridization, some other method if you want to establish that this is an HPV-associated lesion. Now, in terms of these lesions in the sinonasal tract, most commonly these are type 33, which is different than the oropharyngeal cancers, which are usually HPV type 16. So more commonly, we are seeing type 33 in these types of lesions. So I just wanted to just reiterate a little bit about HPV infection. So this is not sinonasal tract, but just to remember that HPV type carcinomas can be deceptively bland. And this is taken from Bishop and Westra's paper in 2015, which shows you a neck cyst. And actually, some of these cancers can be ciliated. And so just because something has cilia does not mean it's benign. So always think about the possibility when you're dealing with something. And these were actually patients presenting with neck masses that had HPV-related cancers. They can be deceptively bland. And so cilia does not mean that something is benign. And actually, you can look in the epithelium here, and you do see that there are mitotic figures. So there was something going on in this. But originally, some of these things are called benign because of the ciliated surface epithelium. So just keep that in mind. And this is an example of a case that we had that was referred in here, which was a lymph node in a 52-year-old male, so almost 5 centimeters, level 2. And we had these cystic areas. I think the person that sent the case in was feeling it was cancer, but they weren't sure because, again, it had this very bland areas within the mass. But as we looked into it further, we actually recommended doing a P16 stain, and the patient wound up having a primary in the right base of tongue. So this was a very bland-looking oropharyngeal cancer. So just always keep in mind that sometimes these HPV-related tumors can be very bland. So we'll move on to the second case, which is a 61-year-old female with a neoplasm of the maxilla and the anterior skull base. So in terms of what we see here, actually sort of a little bit similar to the last case, another undifferentiated malignant tumor. Maybe in this one the cells look a little bit bigger, but we have a sheet of cells, we have some vessels, but you'd have a very broad differential diagnosis for this. Looking at a little bit higher power, again, we have large cells with some pinky eosinophilic cytoplasm, lots of mitoses. So again, we're dealing with an undifferentiated tumor, and here's just a higher power, just showing us this very undifferentiated morphology. So we have, again, for this one, we'd have a very broad differential diagnosis, and I think almost nothing can be excluded with the exception of likely lymphoma. It doesn't really look like lymphoma, but I think everything else is probably still on your list in this differential. So if we looked around a little bit further, there were some things that began to give us clues as to what we think could be going on, and we had these cells with some clear cytoplasm. Here's just another area, cells with clearish cytoplasm, some with the nuclei pushed off to the side. And so that began to shape the differential a little bit more, which we'll talk about. And as expected, this lesion was keratin positive, negative for a whole bunch of markers, and we'll talk about why doing these types of markers in these undifferentiated tumors is important, but negative for melanoma markers, negative for neuroendocrine markers, negative for P16, negative for EBV, negative for NUT, and negative for CD99, which would be a marker for the Ewing family tumor. But the interesting thing is seeing those cells with that clearing of the cytoplasm had the pathologist think to do one more stain, and that was the SMARCB1 or INI1, and that was lost in this lesion. And so this is an example of a SMARCB1 or INI1 deficient sinonasal carcinoma. Now, in terms of SMARCB1, it's a tumor suppressor gene located on chromosome 22. It's part of a large protein complex, the SWIFT sucrose non-fermentable protein, which is involved in remodeling and regulation of gene expression. And the protein is expressed in normal tissue. So it's the loss of the protein is what we're examining by immunohistochemistry. So in terms of this, the gene inactivation in these tumors are tumors that share a rhabdoid or plasmacytoid morphology or an differentiated histology. And so we'll talk a little bit about more, so tumors like rhabdoid tumors and things like that are those that have lost their expression of INI1. It's unknown, and the WHO does not separate this as a separate entity. This is still classified under the sinonasal undifferentiated carcinomas. But it helps us to think about that sinonasal undifferentiated carcinoma is probably becoming more of a wastebasket diagnosis of a variety of different types of tumors that have different loss of certain proteins causing that histology. So in terms of this, and obviously we won't go through this whole thing, but this SWI/SNF complex, there are a lot of different subunits to it, and it's interesting because loss of a lot of these different subunits has been results in a variety of different types of malignancies. So I think as we learn more about this, we'll hear about more tumors associated with this protein complex. So in terms of the SMARCB1 deficient sinonasal carcinomas, in the papers out there, again, this is not a very commonly described lesion. From the largest series, more commonly seen in females, usually in their 50s, and the most common histology is that of a non-keratinizing squamous or basaloid type carcinoma. And the other lesion that these have often been classified as have been the sinonasal undifferentiated carcinomas. In some series, there are reports that maybe they mimic myoepithelial or non-intestinal adenocarcinomas, but more commonly you're seeing this more basaloid carcinoma or this sinonasal undifferentiated carcinoma. Now, the thing that usually is seen in these is a basaloid histology or these plasmacytoid rhabdoid features. You should not really see an in situ squamous component, but sometimes the cells, just like in a lot of different types of tumors, can spread in a pagetoid fashion into the surface epithelium. So in terms of immunohistochemistry, the most common thing you'll see, obviously, is the loss of the INI1 protein complex. These should be keratin positive, and usually a pancytokeratin is what we do most. They might express CK5 or 7. You can see P63 focal or diffuse, and P16 rarely, but they're not HPV associated, so you have to do your HPV studies. And then some have described neuroendocrine type of markers, usually focal. And so you can see that a lot of this immunohistochemistry is sort of non-specific. So really you're coming into the loss of the protein as what's defining how you call the neoplasm. And they should be negative for NUT, EBV, HPV by in situ hybridization or PCR. So these lesions are aggressive, as you can tell from the histology that we see here. They can recur, they can distantly metastasize, and there's a very high mortality at this point in time. So in terms of this, I just thought it was a good time to review the other types of these SMARCB1 deficient tumors. So the sinonasal tumors have been the more recently described, but these were originally described in these rhabdoid tumors of the CNS, rhabdoid tumors of the kidney, so epithelioid sarcoma. So there's a whole host of tumors, and it's interesting at how varied their histology is. But the loss of this protein has been associated with a variety of different types of malignancies. Now, this is just a picture taken from a paper in 2017, which shows a sort of a very undifferentiated sinonasal tumor. And so you think, well, could it be one of these SMARCB1 deficient tumors? But this is actually a SMARCA4 deficient sinonasal carcinoma. And so I'm sure, as I said before, we'll probably see a whole variety of different types of lesions associated with deficits of these proteins. So SMARCA4 deficient neoplasms, probably the most common that you may have heard, is the small cell carcinoma of the ovary, the hypercalcemic type. So that has been associated with loss of this protein. And then a whole variety of different types of other tumors have been described. So in terms of our next case, so we have, this is a younger male, so 33 years old. He has a complex sinus mass concerning for malignancy. And in terms of the histology here, you can see it actually sort of resembles the first so many cases that we've seen, a very undifferentiated tumor. So we have nests of cells, and we have some features that will concentrate a little bit more as we get a little bit higher power. And so undifferentiated tumor, there's nothing that really tells me looking at these cells what the histology is of. But we have a feature that has begins to help us a little bit more. These abrupt areas that look squamous in nature. And here's just another area of these very basaloid undifferentiated cells, and then this area of squamous differentiation. And actually in this area here, we can see that we have a hyperkeratotic stroma. So we're dealing with something that we believe is squamous in origin. And so that helps our differential as we begin to think a little bit more about what's going on in this tumor. So I think we have a broad differential. We still have a lot of these things in our differential. But we can take away lymphoma. I think you can take away olfactory neuroblastoma, and we can take away melanoma and probably rhabdomyosarcoma. So we're left with carcinomas, and actually the Ewing family tumor, which we'll talk a little bit more about, can be there are some of them that might show squamous differentiation. So that's something that's still in our differential at this point in time. So if we do our immunohistochemistry, this is a positive for pancytic keratin, negative for a variety of neuroendocrine markers, melanoma markers, negative for P16, and negative for EBER. And then the one thing, especially we're seeing that abrupt area of squamous differentiation, the pathologist working up this case added one more stain, and that was the NUT immunohistochemistry. And so that was strongly positive. So this is an example of a NUT midline carcinoma, which actually are fairly common in the sinonasal tract. So the NUT midline carcinoma, so there's a series of carcinomas described by French at the Brigham, and these were very aggressive, poorly differentiated tumors that had these areas of squamous differentiation. They're characterized by a rearrangement of the NUT-M1 protein to the BRD4, the promodomain containing protein on chromosome 19. And so that's the most common translocation that you see in this tumor, resulting in this phenotype of this undifferentiated carcinoma that has areas of squamous differentiation. In the past, these may have been referred to as the sinonasal undifferentiated carcinomas with squamous differentiation. So in terms of these lesions are usually seen in younger adults. A good proportion, so when they were first described, the sinonasal tract was not considered. They were actually thought to be more commonly seen in children. Some were described in the mediastinum and then in the bladder. But as people began to investigate further the sinonasal tract tumors, they actually found that a good majority of them do occur in this area. And so the best way to diagnose it is to actually do the immunohistochemistry for the NUT protein or look for the NUT gene rearrangement by either FISH or PCR. The NUT positivity for the immunohistochemistry, so sometimes that can be variable, but it should be diffusely strongly positive in more than 50% of the cells to call it a NUT carcinoma. These are uniformly fatal. Usually the median survival of about 7 months, but actually, and that's why I think finding these different translocations is very important, because they are beginning to see some responses to bromodomain inhibitors, bromodomain inhibitors. So as we become more and more, the ability to diagnose these types of lesions, hopefully they'll be able to develop therapies for these patients, for these uniformly fatal neoplasms. So in terms of NUT midline carcinoma immunohistochemistry, positive for cytokeratins, they're positive for P63. About 50% of cases will show strong positivity for CD34, and then obviously they must be positive for the NUT protein. And like I said, that should be in more than 50% of the cells. And then negative for a whole host of other markers. So they've been shown to be negative for melanoma, neuroendocrine, negative for rhabdomyosarcoma markers, and you can see a whole variety of different other things, and negative for the viral HPV and EBV. And so this is an example that I put up here now of a case, and actually you can see with a very undifferentiated carcinoma of the sinonasal tract, and we had this sort of moderate staining with the NUT antibody, and it was maybe about 50%, but it wasn't very strong compared to what we had seen. But we decided that we would at least confirm in this case, whether or not this was a nut midline carcinoma. And this case actually had no rearrangement by in situ hybridization, so you really have to have that very diffuse, strong staining for something to be regarded as positive. So in terms of sinonasal undifferentiated carcinomas, I think we're now coming to a point where these tumors are diminishing with advancing molecular techniques. So we now have nut rearranged carcinomas, we have these HPV-related carcinomas with adenoid cystic type features, we have adamantinoma like Ewing family tumor, which we'll talk a little bit about. Now we have also these SMARCB1 or SMARCA4 deficient tumors. So this SNUC has now become a diagnosis of exclusion and should not be made really if there's a lot of squamous or neuroendocrine differentiation, and should not be made if you have viral proteins. So it's becoming more of a diagnosis of exclusion. Now, in terms of the workup suggested IHC when you're dealing with these undifferentiated carcinomas in the sinonasal tract, for a SNUC, they should be pan-CK positive, usually low molecular weight, and CK7 positive. They should be negative for the high molecular weight cytokeratins. And if you have diffuse positivity for P40, P63 neuroendocrine markers, that should negate the diagnosis of a sinonasal undifferentiated carcinoma. So usually just doing those low molecular weight cytokeratins should be what you're seeing. And if you begin to see especially strong positivity for squamous markers, you should be rethinking that diagnosis. So other things to do when you're dealing with an undifferentiated carcinoma is establishing whether or not it's HPV associated, EBV associated, and then is it a nut carcinoma or is it one of the carcinomas associated with the SMARC protein loss. Now here's just an example of recently a case that we had, which we wound up calling a sinonasal undifferentiated carcinoma. You can see it's similar to many of the cases that we've already shown, nests of neoplastic cells, markedly atypical, mitotically active, and this wound up to be negative for all of the markers that we have previously discussed. So here's another example of an undifferentiated carcinoma, and this is a 31-year-old female, left-sided sinonasal mass, which was resected. And so you can see this lesion here is very cellular and very vascular with a lot of fibrostroma between these nests of cells. Well, you can see it's very undifferentiated. Here's just another area here, very little cytoplasm to the cells, so we really can't tell much of what's going on in this lesion. And again, very undifferentiated, mitotically active, little cytoplasm, some necrosis, so we have no problem saying whether it's malignant or not. And so in one peculiar area, though, we had sort of nests of these basaloid type cells with peripheral palisading at the edges and sort of this basement membrane type material in the middle. And so I think our differential in this, if we go through what we had been talking about before, we still have a variety of different things in the differential. I think we take away lymphoma, and that's probably pretty much all we can take away at this point because we haven't established everything else. It still could be some of these other types of lesions. So in terms of immunohistochemistry, and this was one of my colleagues worked this up and then brought this to me, and so some of the work up had been done on the outside as well. So this was positive for cytokeratin, it was positive for pan-cytokeratin. The pathologist on the outside had done a GATA3, thinking about was it a metastasis or something. It had some chromogranin positivity and it did have retained SMARCB1. So it was not a undifferentiated carcinoma associated with INI1 deficiency. And then it was negative for synapto, negative for S100, negative for muscle markers, and the WT1 will be being negative, and I'll explain that in a while why that's important. And then because of this GATA3, the pathologist wanted to make sure it was negative for breast markers. And so this is one where actually Twitter sort of came to the rescue when when my fellow brought this to me. One of the things I thought about was like, what could this be? You know, is this some undifferentiated carcinoma? It's Keratin positive. And as he was walking out of the office, I said, you know, there's one more stain that you didn't do, and that's the CD99. And so this was strongly CD99 positive. So you see this nice membrane staining in about 100% of the cells. And it had an EWSR rearrangement by Fish, and then we added on the Fly1 immunohistochemistry to show the Fly1 protein in this. So this is an example of an Adenocarcinoma-like Ewing family tumor, and this was described, well, these have been known for a long time, but Dr. Bishop put them together in a series in 2015, which described that these can actually occur in head and neck sites, and so we need to consider them. So while first described in the long bones as a type of Ewing sarcoma with epithelial differentiation, and actually most commonly squamous, Dr. Bishop then began to see that in the sinonasal tract, in the thyroid and parotid, and in the orbit, they have seen examples of these lesions, although not very common. So in terms of these lesions histologically, as we saw in our case, nested growth, a very basaloid appearance, areas of fibrosis, and then sometimes you can see squamous pearls. And so you might be thinking of a squamous cell carcinoma, but it may actually be this lesion. Mitotic activity, necrosis, and as we saw in our case, is hyaline basement membrane-like material in the epithelioid type cells. So in terms of these, your differential is going to be very broad. And so that's why I think when you're looking at sinonasal tract tumors, you have to have a very broad differential that includes epithelial and non-epithelial lesions. So if you're looking at these, you have a variety of carcinomas that might come into your differential. And then you have to think of non-epithelial tumors. So the non-epithelial tumors to think about would be an olfactory neuroblastoma, synovial sarcoma, and you could do the translocations for the SYT. But in addition, a thing that you may think about in this area that would have an EWS translocation would be a desmoplastic small brown cell tumor. And in these, the translocation involves the Wilms tumor gene. So you should have the expression of Wilms tumor protein in the lesional cells if it is that lesion. And in our case, that was negative. And so the pathologist thought to do both of those stains for the differential of this Ewing family tumor. So in terms of these, immunohistochemistry, CD99 is something which is a good marker to consider when you're dealing with a lot of these types of sinonasal tumors. They're Keratin positive, so just doing a Keratin could lead you down the wrong path of just calling this a carcinoma. P40 and P63 are also strongly positive in these types of Ewing family tumor. And so again, that could lead you down to calling something a squamous cell carcinoma. You rarely might see some expression of neuroendocrine markers. These should be, they might express P16, but they should be negative by HPV by doing additional ancillary studies. And then you should see the EWSR Fly1 rearrangement by Fish, or if you want to do PCR for that. Now remember, this rearrangement can be seen in other types of tumors. So just the presence of a rearrangement without seeing the partner, you have to think about other types of lesions like myoepithelial tumors and things like that. And the prognosis at this point, there's so few cases that it's really hard to know exactly how they do. So in terms of just a nice study that I had seen in 2009 from Cordis in Human Pathology, they had this great table that says really when you're working up these undifferentiated sinonasal tumors, a very broad approach is necessary. So doing keratins, neuroendocrine markers, ruling out rhabdomyosarcomas with the Desmin, and ruling out melanomas. But some of the things I want to add here is that things that we might have to consider is that when we get to this undifferentiated tumor, we've now added a whole variety of different types of lesions. So we have to do the NUT, we have to do the SMART proteins, we have to look for HPV and EBV And then in addition that we now know that rhabdos, melanomas, Ewing family tumor, olfactory neuroblastomas may express keratins, at least focally. So that's something that we want to, so even if you have some keratin positivity, you still have to consider those lesions. And then don't forget to do your CD99 and your gene rearrangements for the EWSR gene to exclude Ewing family tumor. Now, I wanted to just change gears a little bit in the remaining time to talk about some additional tumors that we've seen. So we did a lot of undifferentiated tumors. These are a little bit more differentiated. This was a young woman who had a sinonasal mass. If we look at the histology here, it was actually these very closely packed, very bland-looking glands, but they were infiltrating in the submucosa and also focally infiltrating into the bone. If we look under higher power here, very bland-looking, nicely formed glands, very little stroma between the glands. And this was actually by my colleague, Dr. Lavolsi. She had been looking at this and said that, you know, based on the infiltrating pattern, she felt this was a sinonasal adenocarcinoma, but there was something funny about it. It just didn't look typical. And one of the things that I learned from her, she says, I'm not exactly sure what it is, but I know, you know, probably in 2 weeks, there'll be a paper in AJSP describing it. And it wasn't 2 weeks, but it was a couple years later. There was this paper by the Hopkins group that talked about these low-grade sinonasal adenocarcinomas that had this non-intestinal phenotype and were associated with an ETV6 gene rearrangement. And these are the papers, these are the pictures from that paper showing these very bland glands, very similar to what we had. And it was very interesting because it had this particular staining with dog1 of a membranous pattern, or of a luminal pattern in the cells, and sort of a patchy staining for S100. So when this paper came back, we went back to our case and we saw a very similar thing. So strongly SOX10 positive, S100 sort of patchy, and then this luminal staining with dog1. And so, interestingly, you know, we began to think that maybe this was one of these types of ETV6 rearranged tumors. So these ETV6 rearranged low-grade sinonasal adenocarcinomas, very rare at this point in time. I think now they're up to maybe 5 reported cases. So the original report was on 3 cases. They can be seen at any age. They usually act in a low-grade fashion, so they can recur, but they don't metastasize. We talked about the immunohistochemistry that you see with these lesions. And then interestingly, in the first study, these were shown to have an ETV6 rearrangement, usually with NTRK, in at least, you know, of these 3 cases, 2 of them, and then 1 had an unknown partner. And a more recent study has shown 2 or 3 lesions associated with the RET gene. So there's some overlap with these lesions with salivary gland secretory carcinoma, and so more has to be done with them. But the interesting thing with our case, even though it histologically looked exactly like what had been described, we did not find any ETV6 rearrangement. So maybe this is a rearrangement of some other type of gene or something in this patient. Okay, so next case, we have a 78-year-old male with a sphenoid and cavernous sinus mass. And this was a very interesting histology because we had never seen this before, but again, you know, rare things happen. And so we had a very hemorrhagic lesion composed of these clear cells that were sort of bland in appearance. And even at this power here, we kept saying, this looks like a metastatic renal cell carcinoma. Are you sure the patient doesn't have renal cell carcinoma? Here's another area here. So these clear cells, very bland, minimal mitoses, very hemorrhagic. And here's just another area. These clear cells, very vascular. And we were assured that there was no evidence of a tumor elsewhere. And so it was positive for keratins, also positive for some markers that you might see in a renal cell carcinoma, but negative for a whole variety of different other types of markers. So this is actually an example of a sinonasal renal cell-like adenocarcinoma. So I think you have to exclude a metastatic renal cell, but there is this category of lesions, which is now still classified under adenocarcinoma in the WHO. Very rare, reported less than 20 cases reported in the literature. Mean age 54, again, more commonly seen in women, very low grade, no history, when you're doing these, looking at these lesions, no history of renal cell carcinoma, no history of other types of malignancies that can have a clear cell phenotype. And there's some thought of, there have been some lesions that have been described in patients with VHL of these microcystic adenomas. So there's some thought of, are these two entities that are related to one another? And with how infrequent these lesions are, it's been very hard to put studies together. Often positive for cytokeratin 7. They can express the CA9, and which can be seen obviously in renal cells. So some of the stains don't necessarily help. People thought PAX8 might be helpful in working up these lesions. The initial cases have been found to be PAX8 negative, but subsequent studies have shown PAX8 positivity. So that does not exclude that it's not just one of these renal cell-like carcinomas. So you need to rule out renal cell. This is just an example of a case that we had, which was a sinonasal metastasis of a renal cell carcinoma, and it looks very histologically similar. Even with the hemorrhage, which is characteristic of renal cell, you often see that in these renal cell-like carcinomas. Now here's one more tumor that we saw in a 74-year-old extradural tumor compressing the right frontal lobe. And you can see in this one, this is more spindly. So we have this intact sinonasal mucosa and the submucosa with these very bland-looking spindle cells growing in these fascicles, just higher power, just showing sort of the growth pattern here of the fascicles of these spindle cells. No necrosis, very minimal mitotic activity. In some areas, it was a little bit hypocellular, so sort of these wavy fibers, almost neural-like in appearance. And just a higher power here, just showing how bland, very minimal mitotic activity, no necrosis, but it was invading into bone, as you can see here. So there was no problem saying that it was a malignancy. And in terms of immunohistochemistry, so this was strongly positive for muscle markers, so smooth muscle actin as well as S100, very low proliferative activity with Ki67, and actually nuclear beta-catenin in a proportion of the cells. So in terms of what we saw, so we saw these positive markers, and then negative for a whole host of other markers. So negative for melanoma markers, negative for muscle markers other than the SMA, so it was not a rhabdo, and negative for a whole host of other types of markers, as well as the negative for FISH for synovial sarcoma. And so this is an example of a biphenotypic sinonasal sarcoma, or low-grade sinonasal sarcoma with neural and myogenic differentiation was the original term used for this lesion. So these, again, like many of the lesions that we've discussed already, more commonly seen in women, usually age of 50s or so, often seen as a superior or ethmoid mass. And these act in a low-grade fashion. So there's been no reports of metastases, but one patient has died of the disease, so it's a locally recurring problem. And we've seen a couple patients that have had multiple surgeries to resect these lesions. So in terms of what we see, so a low-grade spindle cell neoplasm, it's usually very vascular, so you might see some staghorn vessels, should not see necrosis or significant mitotic activity. And you have a significant differential diagnosis when you're looking at these. Cellular schwannoma, malignant peripheral nerve sheath tumor would probably be the more common that you're thinking about, but also solitary fibrous tumor, cholangioperiscytoma and synovial sarcoma would be all things that you may want to exclude when you're dealing with these neoplasms. So in terms of the immunohistochemistry, you should have the biphenotypic nature, so they should be positive for S100 and also positive for smooth muscle actin, and they will express nuclear beta-catenin. You will have very variable results with other types of stains, and they should be negative for SOX10, so that excludes a melanoma or a schwannoma. And so the most helpful panel when you're dealing with these lesions is it being S100 positive, SMA positive, beta-catenin in the nucleus positive, and then SOX10 negative. So that's your most useful panel because it might express some other types of markers. So it's really these markers that are very strongly support the diagnosis. So in terms of these, just like many sarcomas and many things that we've talked about so far today, there are particular gene rearrangements that have been identified in these tumors, and most commonly it's the PAX3 gene on chromosome 2 with the MAML3 gene. So a good proportion, so over 50% of patients will have this rearrangement, and then PAX3 with an unknown thing, and actually probably another high proportion of patients. Interestingly, though, you may see PAX3 with FOXO1 or NCOA1 in a small proportion of cases, but that has actually been seen in some of the tumors that have expressed some rhabdomyoblastic differentiation. So they're not truly expressing it in a lot of cells, but they have a proportion of cells that are expressing myogenin. So that's just been an interesting association, but it has not, as far as they know, have any prognostic significance. So I want just to do one more case, and this was actually a 56-year-old female with a large mass, and actually it was resected after they had 2 negative biopsies. And I think they were negative because of how bland this initially presented. So what we had, this is actually this large polypoid mass that the surgeon took out pretty intact. You can see this intact mucosa. And one of the things that we began to think about, is this just some big funny polyp? Is it a respiratory epithelial adenomatous hamartoma because of these glands? But the stroma just looked weird. It had areas that were hypo and hypercellular, and it had some areas, actually you can even see here, that were a little bit more keloidal. So there was something funny with the stroma as we looked at this polypoid mass. And so we could see how the biopsy would be very nonspecific, because if they just got a small piece of that, you probably just thought it was some fibrosis. But as we got a little bit higher, you can actually see this keloidal fibrosis here, and some areas that had this more cellular spindle cell proliferation. And you can actually see it here. So alternating areas, hyper and hypocellularity, very bland, minimal mitotic activity, and no necrosis, and strongly positive for CD34, and strongly positive for STAT6. So this is an example of a sinonasal solitary fibrous tumor. And so while not really a newer entity, I thought I would just include it because it's something that you should consider in your differential diagnosis of a spindle cell lesion in the sinonasal tract. And so these do occur. And in fact, actually, there was just a paper that came out about a month or so ago from Dr. Thompson, adding more to what has been described in the literature. And so it's for solitary fibrous tumor. The most common area that's involved by this is the sinonasal tract. And so about 80% of, about 30% of solitary fibrous tumors are identified in the head and neck site, and the nasal cavity would be one of those common areas. So most of them are occurring in the ones that are occurring in the sinonasal tract are usually seen in the nasal cavity. They will express the marker, so the STAT6, which is sort of by the gene fusion of the NAB2 with STAT6 gene, resulting in the STAT6 protein. And these have a relatively good prognosis, but the WHO does classify them as low or uncertain malignant potential. But so far, they have not had, as far as I know, no deaths associated and just risks for recurrence if not completely resected. So here's just going back to our, as we finish up here, so going back to our sinonasal tract malignancies, and what I've highlighted in blue are actually all of the changes that we've seen in the WHO in the past 10 years. So we've added a whole host of different types of tumors. So in the carcinomas, we have the nut carcinomas. We've added this HPV multiphenotypic carcinoma. We now have a whole host of sinonasal undifferentiated carcinomas associated with deficiencies in specific proteins such as SMARCB1 and SMARCA4. In terms of adenocarcinomas, we've added this ETV6 rearranged as well as this renal cell-like carcinoma. And we've expanded the neuroectodermal to include this adamantinoma-like Ewing family tumor. And then we've also added these other types of tumors, particularly this biphenotypic sinonasal sarcoma. So in what we've seen over the past 10 years has been this growth in sort of the characterization of these lesions in this area. So just to summarize, the sinonasal tract, very diverse, unique neoplasms, and interestingly, a lot of overlap, both clinically and histologically. And basically, our approach is to do this very broad immunohistochemistry as well as molecular profiling to look at these lesions so that you can accurately classify them. And while at this point there might not be targetable therapy, I think as we go further with better characterization, we'll be able to help some of these patients that have these, especially these undifferentiated malignant neoplasms. So I would like to stop there, and we'll be happy to answer any questions that anybody has.
Thank you so much, Dr. Montone, for this highly educative discussion on the recently described sinonasal tract tumors. You would be very happy to know that you had online viewers from so many different countries, including Myanmar, Philippines, Tanzania, Syria, Taiwan, Peru, Argentina, among others. Thank you, viewers, for joining in. I have a couple of questions that I saw online. There is one question from Minesh Gandhi who wants to know if P16 alone is sufficient or it should be coupled with a method to detect HPV-33 in HPV-associated adenoid cystic carcinoma.
Yes, the CAP guidelines, so the College of American Pathologists, suggests that P16 is sufficient only for oropharyngeal carcinomas. So for any type of tumor outside the oropharynx, you need to couple it with another method to establish that it's HPV associated. Now, if somebody doesn't have access to those, I mean, since there's not a prognostic associated with that, if somebody had a strong P16 positive tumor that looked adenoid cystic-like, I think it would be okay to term the lesion, but they really, at least the recommendations are that you couple it with another HPV method.
Thank you, Dr. Montone. So there is another question from Minesh. So he who wants to know what marker to choose, whether it is P63 or P40 in sinonasal undifferentiated carcinoma.
I would if I were to do one of them, I'd probably do the P40 because I feel that's been described as a better marker for squamous cell carcinoma, and so it should be in one of these, in those lesions, it should be just maybe patchy positive. If it's strongly positive, you may want to think about this being a tumor with squamous differentiation, or a Ewing family tumor, as we have seen.
Right. These are the questions that I saw online so far. And once again, thank you so much, Dr. Montone, for your time. And thank you, viewers, for joining in. And please stay tuned for upcoming lectures on PathCast. Please feel free to subscribe to our YouTube channel, follow us on Twitter, and follow our Facebook page. And as well, you can access to all our archive lectures logging into our website, that is pathologycast.com. Thank you again so much. Thanks a lot.
Okay, thank you.